Thank you, Mr. Chairman. Good morning. It's my great pleasure to be here today, and thank you for organizing committee for accepting my case. So today I will speak about one case and to see how navigating the complex intersection of the patient with the acute ST segment elevation myocardial infarction. At the same time, he has cardiogenic shock and intracranial hemorrhage. So this is a gentleman, a 74-year-old man. He has multiple cardiovascular risk factors, including hypertension and diabetes type 2. Unfortunately, this patient had a chest pain and went into one of the peripheral hospital with the diagnosis of inferior posterior ST segment elevation myocardial infarction, as seen by this ECG. And that hospital, they don't have coronary angio, and they have some logistics. So they decided to give this patient full thrombolytic therapy. Unfortunately, after 2 hours, the patient is still having ongoing chest pain, and he went into cardiogenic shock, and they started with him on high-dose vasopressors and still persistent ST segment elevation on the ECG. So failed the thrombolysis, and the patient went into cardiogenic shock. At that time, the patient in blood pressure 90/50 on high dose of vasopressors, heart rate 140, and the patient became more ill. He became ill and having pain. So they contacted me. We are the nearest hospital to that hospital. And he told me this patient have chest pain, but unfortunately, still the patient have projectile vomiting. So I told him, please just do brain CT and send the patient to me immediately. Unfortunately, when the patient came and we reviewed the CT scan, it showed this hemorrhage. For this man, it's considered a big hemorrhage in the posterior part of the brain. It's considered a big hemorrhage. So now I am in front of a big dilemma. Old age patient with STEMI, failed thrombolysis, he's in cardiogenic shock, persistent ST segment elevation, and at the same time, he has intracranial hemorrhage. So what to do? We debated in our department, or just leave him and observe him, but the patient is unstable. We cannot do that. Conservative, just give aspirin and Plavix. But again, the patient in cardiogenic shock, still chest pain. So this is, again, is not an option. So the other options is neurosurgical opinion. We called the neurosurgery immediately. That time was 11 night. And as usual, neurosurgeon, he cleaned his hand and he said, I cannot do anything. The other option is to just give a mechanical circulatory support. But again, we need anticoagulation for mechanical circulatory support. So I decided just to take the patient to the cath lab, just to see what's going on. Probably if there is total occlusion of the artery, I just aspirate the thrombus and that's all. And that's what the coronary angio at the beginning. Sorry, these are because of diagnostic angios. You see that separate OST of probably left main LAD, but there is a big and dominant circumflex with the tight lesion at mid portion. Probably there is even a thrombus. LAD also there is a lesion at the mid portion. Here more views. The circ is the big dominant artery. Probably this is the calibrate artery. And there is, again, tight lesion of the ostium of the circumflex followed by the ectasia. The RCA is small, also disease, but small. And we decided just probably at the beginning, I said, okay, I will just put a wire, aspirate the thrombus from the left circumflex, and that's all. While we are doing that, and I'm discussing with the nurses with me, the patient become more unstable. So more chest pain, ECG becomes sky high, and patient become irritable. If you look to this image, here now the artery become total, even become more bad. So probably this is because of, probably because with the injection, the thrombus moved. So at this time, I opted just to do anything. I put a wire. I tried multiple times with manual aspiration, but I failed. Nothing can be retrieved. So I decided just to dilate this thrombus, to crush this thrombus, dilate this artery. And now what to do? I have to put a stent. So that time, with that stage, I decided to put one of the stent, which is approved to have only 1 month dual antiplatelet. Despite this patient having acute coronary syndrome, but at least 1 month dual antiplatelet therapy with this stent is better, which is by Freedom Ultra. This stent is available, and I put this stent. I didn't went to high pressure. I want just to improve the flow. And if you look to this image, now the flow is okay. The patient started to slightly improved. The blood pressure improved, chest pain improved. And we took the patient out of the cath lab with these images. And next day, now what to do? The patient have a stent now in the left circumflex. And he has a MI, and he has intracranial hemorrhage. So I decided to give him only clopidogrel. I didn't give him any aspirin. I didn't give him any anticoagulation. I kept him only on clopidogrel, and I followed the patient with the neurosurgeon every day. We repeated the CT scan and clinically 3 times. Actually, the patient kept in our hospital for 10 days. Over these 10 days, I repeat the CT scan 3 times. Fortunately, there is no deterioration in the intracranial hemorrhage. The patient significantly improved. Second day out of cardiogenic shock, I removed all the vasopressors, and I kept him only on clopidogrel. So with this brain image, with this ECG, I discharged the patient. Patient went, I saw him 2 weeks later. He's in good shape. He has no chest pain. He is not in heart failure. And he has only some slurring of the speech or some mild weakness. That's all. Otherwise, he's fully conscious. He's awake and he's doing his activities. We discussed with him to finish because still there is a lesion in the LAD, still a lesion in the circ. But the patient, he don't want to continue with us because he suffered too much with us. So the patient went to the other hospital and finished the other procedures. So I reviewed the literatures to see if there is any cases like these cases, patient with cardiogenic shock, ST elevation, MI, intracranial hemorrhage, and I found few cases, actually 8 cases reported the patient have intracranial hemorrhage with acute MI, and only from these 8 cases, only 3 cases they did PCI. 2 of them they died later on, only 1 survived. And one recent case published by our colleague in Saudi Arabia in King Abdulaziz Hospital by Dr. Fahad and his colleagues, and they have the same patient. The patient have inferior ST segment elevation MI, but they managed him conservatively, and luckily that patient survived without any intervention, and they didn't do for him any coronary intervention. So to take home message, because the time is almost finished, there is no well-supported, because I reviewed if there is any well-supported algorithm to manage this type of the patient. We didn't find it clear. So the decision whether to continue or to do or to give antiplatelet or anticoagulation, still debatable, and you have to decide according to the condition of the patient. And the management depends on the expert opinion and multidisciplinary approach, neurosurgeon, neurologist, cardiologist, ICU physician, not only the cardiologist. And the principle, if I read the multiple cases, the principle is close neurological monitoring. So this patient, actually, we monitored him every day with a neurosurgeon, every day, 2 times a day, actually 2 times a day. There's luckily no neurological deterioration. And if we decided if any deterioration in the neurological status, we can interfere from neurosurgical point of view, and avoiding any major cardiovascular event. So I kept my eye every day, ECG, every day I saw the patient. If anything happened in terms of stent thrombosis, probably I have to go again, aspirate thrombus, and that's all. But luckily, this patient went into a very good course and discharged, and now he's in good condition. This procedure done almost 9 months ago, and the patient now still alive and is in good condition. Thank you very much.